Thank you very much to the conference organizers for this opportunity to participate. I am very interested in HIV prevention, although I've dedicated my career to the treatment and prevention of sexually transmitted infections more broadly, and consider those elements to be very, very important for the global control of HIV. So I will focus my remarks this afternoon on global control of sexually transmitted infections. Again, thank you very much for inviting me to participate. Sexually transmitted infections, of course, are those conditions which are transmitted from person to person through sexual contact. They represent a significant cause of morbidity in terms of immediate pain and suffering caused by the infections, but also the long-term sequelae of infection, particularly things like infertility, tubal ovarian abscess, and other long-term complications. They also engender a significant expenditure of resources for society. Many pathogens can be sexually transmitted. As you can see here, a list of bacteria, viruses, and parasites. Many pathogens can be sexually transmitted, but in terms of global control, we focus on the most important ones for which we have either curative therapy or interventions to prevent downstream transmission, including Treponema pallidum, Neisseria gonorrhea, Chlamydia trachomatis, and of course HIV. Getting a sense of the burden of disease is sometimes difficult, and these are data from the World Health Organization, global estimates of curable STI, and this includes not only syphilis, gonorrhea, and chlamydia, but also trichomoniasis. And you can see in the Americas, substantial burden of STI in Central and South America, but really the great burden of these infections occurs in Sub-Saharan Africa and Asia. So the total number of cases, of incident cases per year, are estimated at about 457 million cases. In terms of prevalence, these data give a sense of how many cases are present at any point in time, and you can see up to 300 million cases of curable STI present in the world at any moment. The difficulty, of course, is knowing where these infections are present. The STI epidemiology is defined as the study of the distribution and determinants of sexually transmitted infections. We want to know who, where, and why. We want to identify risk factors and also implement interventions to reduce transmission. We certainly are concerned with primary prevention, that is education, vaccination, anything that would either prevent exposure or prevent infection if exposure occurs, condom usage, but also secondary prevention, which is the diagnosis and treatment of disease in index cases to prevent the spread of disease to other individuals and to prevent the complications that might occur after exposure. So primary and secondary prevention are important for STIs and lead to further prevention of HIV. With my colleagues here at Queen's University in Canada, we've been talking a lot about integrating pre-exposure prophylaxis for HIV into sexually transmitted infection diagnosis and treatment strategies, because individuals who are at risk for HIV also are at risk for STIs, and we may see them in our sexual health clinics with incident STIs. And our goal is to identify people who are seronegative for HIV, but at risk for HIV acquisition, and integrate them into networks of PrEP, pre-exposure prophylaxis treatment. So that is one of our goals here in Canada more broadly. When we're talking about STI epidemiology globally, there is a paucity of data due to incomplete data collection and incomplete data reporting. And estimates are based on sentinel surveillance. We don't have very good surveillance globally. We have to depend on antenatal care clinics and data from other sources to give us a sense of how much disease is present. The World Health Organization estimated from 1995 to 2005, the total number of STIs, I gave you this data earlier, 457 million in 2005, but increased from 333 million, based primarily not on increased morbidity, but on better surveillance. We have a better understanding of where these infections are located and the burden of disease that it's imposed upon. But this just goes to show you that our surveillance data are limited by by the paucity of information that we have available to us, and we must make assumptions about distribution of disease based on limited data. Maternal syphilis is a very important problem, and is important for the elimination of congenital syphilis. And these data give an estimate of seroprevalence. You can see in the Americas region an estimate of 3.9% maternal seroprevalence in the early 2000s. Many countries have actually increased their maternal syphilis surveillance and reduced the spread of congenital syphilis as a result. So the World Health Organization has identified a global strategy for STI control. It was endorsed by the World Health Assembly. It includes both technical recommendations and advocacy recommendations for control of sexually transmitted infections. The technical component really focuses on good quality STI case management, which means correct diagnosis, effective treatment, education and counseling, condom promotion, and partner notification and treatment, as well as avoiding stockouts of essential medicines and supplies. And this is very important, certainly in the COVID era, due to disruptions in the supply chain, which have affected all aspects of medical care globally. It also requires a review of policies, laws, and regulations that would facilitate care seeking for sexually transmitted infections. The advocacy component of the global strategy includes raising awareness, mobilizing resources, and generating partnerships to reduce the spread of STIs. But there are significant barriers to implementing effective STI control programs in developing countries. And these include lack of effective surveillance systems, including reliance on syndromic rather than microbiological diagnosis, which I'll mention in just a moment, and also lack of essential clinical services. So making sure that clinics are staffed with appropriate medical personnel will be important to maintain service delivery. And unfortunately, STIs are often separated from HIV programs, and this lack of integration also impedes the ability of planners to prevent the spread of these infections. So our question is, how do we work towards STI control in developing countries to maintain a global strategy which is effective in both wealthy and less economically privileged countries? Well, the CDC and the World Bank have proposed a strategy of prevention through treatment, starting with clinic-based management of symptomatic sexually transmitted infections, identification and treatment of sex partners, the screening of asymptomatic persons, and targeted STI control measures in core and bridge populations, which would spread the infection to the general population, as well as the use of STI vaccinations, such as human papillomavirus and hepatitis B. Core groups are those groups of individuals which are at greater risk for STI transmission through rapid sex partner change and through low rates of healthcare seeking, low rates of condom use. And they can spread these infections to the general population through bridging units. And so these are population dynamics where we need to focus not just on the core group, but also on the bridge populations that bring it to the general population as well. Other supporting elements of the CDC World Bank solution include leadership and advocacy, surveillance, laboratory capacity, training, and monitoring and evaluation, as well as community education. The diagram shows you with facility-based information, facility-based STI management, how all of these elements can fit in for a global STI strategy. This is a very idealistic approach and of course requires a resource allocation. So ramping up all aspects of this kind of approach will be required for a global, truly global control of sexually transmitted infections. I'll finish on just a description of the clinical services and resource core settings, just to remind everyone that in many parts of the world, STIs are diagnosed syndromically rather than microbiologically. That is based on clinical symptoms and syndromes rather than on the results of laboratory tests. And we know that these are notoriously inaccurate. They assume a knowledge of the likely microbiological causes of the syndromes, but studies have shown that they do not necessarily predict the true microbiologic cause of any individual's condition. The benefits are profound because they're very inexpensive. Syndromic protocols don't require routine laboratory tests. Flow charts can allow nurses to deliver care. You can offer same-day treatment, and it's certainly less expensive, and you can have higher clinical throughput. But there are important pitfalls, and this impedes our ability to achieve STI control globally because we cannot confirm diagnoses microbiologically, and particularly in women, the syndromes do not perform particularly well, and drug resistance and disease rates are not tracked. As well, it's only good for symptomatic patients. Persons with asymptomatic infections are not diagnosed because they don't have a clinical presentation, and it requires surveillance systems and leads to overtreatment, particularly of women. So my final aspect is disparities in STI control. We have robust systems of care in high-income countries, such as effective surveillance, microbiological treatment, asymptomatic screening, and partner management systems for most diseases, whereas low and middle-income countries have incomplete surveillance, syndromic treatment, a lack of asymptomatic screening, and incomplete partner management. As well, other structural barriers exist that prevent true global control, migrant labor and mobile populations, but screening at border crossings and among commercial sex workers can help mitigate these barriers. Certainly issues of sexual assault, gender inequality in all societies, and limited access to sexual and reproductive health education prevent our ability to provide a truly global approach to STI control. And wealth disparities, wealthy nations have better abilities to buffer against the problems than low and middle income countries. So my final slide, what's needed for STI prevention, additional research, additional resources, generating partnerships with donor organizations, raising awareness, and improving our resolve to control these infections. Tengo muchas gracias por la oportunidad de hablar esta tarde.